So welcome everybody. I'd like to spend the next 45 minutes. Here's Alanna
So sorry
presenting.
about that. Issues on my end. I'm here.
We were just about to get started without you, Alanna.
Oh,
Um,
goodness.
so
Sorry about
uh,
that.
yeah. So do you want to kick us off then, Alanna? And I'll go through the slides. Sort of
Oh, sure.
we've got a tag team going on here today,
We do.
and
And it's really just been such a pleasure to work with you, Dr. Vallis, on pulling this together and, taking your guidance on where we can take this discussion because we know that, we're all trained clinically. We want to do a good job working with people and help them improve their outcomes and help their lives with diabetes feel better. But we know we have to take a step back, and to be effective at that, it's so much more than just sharing our clinical knowledge. So we thought we're going to dive into a few things and definitely add comments throughout as we go. We thought we are going to start out here imagining, though, that I'm coming to see Dr. Vallis for the first time, and I'm gonna be my own type 1 person here, and let's kind of see how things maybe could go or not go. So I'm just gonna
yeah.
walk in and sit down.
Thanks, Lon.
Here I
Yeah,
go.
we thought the best way to get started would be just to do a little kind of interactive activity that sort of maybe shows some of the tension. So I want you to imagine that, Alana's been seen in this clinic, that she's been managing with her pump and her CGM, and I'm going to be rushing into the room and I'm going to be sort of just launch into this conversation. So, oh, Alana, nice to see you. I'm really sorry I'm late. Today's been such a challenging day for me, and I thought maybe we could don't have a lot of time today, but let's just kind of get going. And if it's okay, I think there's an issue I need to talk to you about.
Okay.
We had a look at sort of your downloads, and we'd been working on your time and range. It looked like it was doing okay for a while, but it's really taken a turn for the worst. And you know what? We were talking about you just a few minutes ago, and we're really, are you turning off your alarms again, Alana?
Honestly, I just get my kids to bed. I finally get to bed, and those alarms were just going off. There's nights I know I'm high. I just want to sleep. I'd rather just let it be and get a good night's rest and deal with it in the morning.
You have reviewed this though with us, right? Like you know how important it is. Those alarms do the work for you. And so it's going to be really important for you to, keep them on. I know it's tough, but you know what? It's really the best thing that you can do.
Well, sometimes that when I get into my real life, though, sometimes I know I should do that, but it's really hard to follow through on that and do that because I've had some bad experiences, and sometimes I just want to sleep and feel better running a bit high.
Yeah. But then, and look at the consequence. I mean, we saw things improving and now less so.
Well, I guess I don't know. I could try. I had that
All
one really
right.
bad low. That was scary.
All right. So let's time out here. And I just want everybody to reflect on what that conversation was like, right? Busy clinician using lots of I statements, basing
Yeah.
down the data that they've seen. And so, Alana, for you, what was that like?
Oh, I felt like, what am I doing wrong? I can't do what you want me to do. And you don't
Yeah.
understand where I'm coming from and what
Yes.
my life is like outside of just my diabetes,
Yeah.
right?
So let's ask you two questions. Question number one, and this is going to sound potentially odd to the audience. So here we are interacting, and as we're going back and forth, do you want to get closer to me or farther away from me?
I'm looking for the door.
Okay. Okay.
Right?
Question number two. Question
Yeah.
number
When's this
two.
appointment done?
If this session ended now, would you like to come back?
No,
Okay. All right.
no.
So this is the context for our discussion today. And let's sort of carry on here. What are we dealing with
Yeah.
here? And what we're dealing with is really this challenge that we find between sort of expectations and reality. One way of looking at the world, an easy way for health professionals to look at the world, is that the world makes sense. Our job is to, sort of know what's going on, implement a therapy, measure the outcomes. And we kind of look at this as though you put the work in, you get the success. And so if this was the case, that it's simply a matter of knowledge, education, desire to have an outcome, then we would have it would be a transactional relationship.
Mhm.
But the point we want to come away from here is the reality is that you never get to success without going through lots of barriers. And the chances of people going through barriers without support, our support, is really, really low. So the first point we want to make is this issue of understanding that our job is relational, not transactional.
Mhm.
And that's important because the role I was taking on was the busy clinician who was trying to manage their day and making it more about the knowledge, the management components.
Mhm.
So I'll let you introduce this to us, and then
Yeah.
we'll.
Totally. So what we kind of want to go through this morning is how do we, make sure that we're focusing on the relationship, that relational partnership. We're going to talk a lot about shared decision making, everything from shared decision making with those big choices, the therapy decisions, things like using a pump or using a CGM, and also that shared decision making we talk about that's so important with self-management behaviors. And then also how do we ensure that we're getting some alignment, especially with the goals? What's our goals versus what's the person's living with diabetes? What are their goals? And how do we bring those together? So at the beginning, as you just introduced, it's so easy and tempting to fall into that transactional way of working. We have these long checklists of things that we know we need to watch for. What's their time in range? How much are they low? Is their basal bolus insulin balanced? All these things. And, EMRs are helpful, but they don't really help because we feel like there's all these things we have to go through to do our job. But we know that, the time investment to build that relationship is so important to keep people coming in to be effective at what we're doing. So I'm looking forward to, Dr. Vallis walking us through how do we do this? How do we effectively make sure we can still get done what we need to get done, but make sure we work on this relationship?
This one is really, really important. And, the bottom line is unless the person is actually ready to do the work, the relationship we establish is essential.
Mm-hmm.
However, we have to appreciate we're all haven't been trained to be the experts. So, what is our kind of role? How do we kind of view our clinical tasks? And you see them. Our job is to do an assessment, to come up with a diagnosis. Then, based on guidelines and evidence and clinical experience, we implement a treatment and we then measure the outcomes. And so this puts us in the role of the expert. And I want to normalize this to us because this is actually very sort of culturally normative. And what I mean by culturally normative is our culture is the scientific method, evidence-based medicine, the scientific. And Sir Isaac Newton had this idea, it's called the clockwork model. And his idea was the body was like a clock. If it was broken, you could take it apart, find the broken piece, replace it, put it back together. Everything works hunky dory. So reductionism and determinism became the hallmarks of our clinical work. What is the diagnosis? What is the mechanism of action? Here's the problem. Here's the solution. And so what this meant is that as clinical medicine developed, we naturally put ourselves into the role of expert, the expert clinician with the uninformed help seeker. How easy it is for me to look at some printouts and some data and then judge it and say, oh, Alanna, you're not doing as well as we had wanted you to do, right? Because I'm the expert, so I can make these judgments, Alanna, and I'm here to help you. So my duty is to do this. I need to keep you safe. But the problem is that the recommendations in education really amount to teaching and telling.
Yeah.
Let me tell you what the problem is. Let me tell you what the solution is. There are dangers to teach and tell. So when we take the role of expert, here's the problem. Problem number one, the patient will try your advice. This is scary. I mean, I want you to reflect. How often in diabetes do we hear the following? My doctor wants me to, my nurse wants me to, my diabetes nurse has, my dietitian has asked me to, my psychologist says I should. That, right? That how often do you hear people saying, this behavior is for somebody else?
Yeah.
I need you to know what happens when people do a behavior, but it's not internally motivated. And here's what happens. They try, but it's not their idea. So they run into a barrier and they stop. Then they try again and they stop. They try again. How much behavior changes in the 2 weeks before a medical appointment? And there's a perfect example. People do a lot of behavior in anticipation of seeing their clinician, but they're doing it for the clinician. And
Mm-hmm.
what you see here, I try, it doesn't work. I try, it doesn't work. I try, it doesn't work. I don't keep trying. This is a really powerful phenomenon called learned helplessness. It's almost like depression. And the challenge with it is that once you develop it, you then lose this sense of confidence in yourself. So, one of the dangers of teaching and telling is that we'll set people up for failure and
Mm-hmm.
then they'll give up on themselves.
Mm-hmm.
Now, ironically, there's a second danger to teach and tell, and that is they will resist us. And again, you know, I'm sorry to tell you this, Alanna, but I'm sure you've heard it that, dietitians and
Yeah.
diabetes are sometimes referred to as the food police.
Yeah.
Where does that come from, right? And where it comes from is human nature. And so, how old was a child when they first declare, "You're not the boss of me"? Every child does it, usually 18 to 24 months. Amongst the first words, it's not mommy or daddy. It's usually no, followed by me too.
Yeah.
And the more you tell someone what to do, the more they will resist. This is called psychological reactance, the tendency to act in the opposite way to what you're asked to do. And it's related to self-determination and control. Tell me what to do and I'll tell you where to go. And so what's important to understand here is that it's about the connection. When you're the expert, you might set the person up for failure or you might set the person up to push back against you. That's why we believe that it's really, really about the relationship
Mm-hmm.
and building a partnership. So we're going to go through a few cases and try to sort of continue this conversation. We'll be fairly efficient. We're going to talk about 3 patients, and we'll be fairly efficient in doing so, so we can leave some time for the end. But maybe I'll ask you to get started with James.
Sure. So here's James. He's a 28-year-old, lived with type 1 diabetes since he was a kid. I see a lot like James, where he left pediatric center. He went out and just started being followed by his family doctor and has just been kind of doing his own thing since then. And just got referred to an endocrinologist, though, because his A1C started to creep up. So he's just now come to see you as a diabetes educator in clinic. And if we advance forward, you kind of feel like, all right, we want to welcome him. I want him to feel comfortable. Hi, welcome. How are you doing? And then you get this one word answer back. Fine. You feel that awkward silence. You look at that referral and it's just this A1C 9.5 needs education. You don't really have a lot of other juice there. So, we've all been trained. Let's ask an open-ended question. What brings you here today? And his response is, my endo wanted me to come. I go, okay, feeling a little stuck right now. So I think many of us, our knee-jerk reaction might be, okay, well, I got 45 minutes. I've never met him before. Let's just start with your questions. I've got all my assessment questions that I need to go through to kind of understand his diabetes and how I might be able to help him, right? That's kind of how our brains, I think how our training tends to take us. So I'm tempted to go, let's start out with these questions. Now, is this effective though, Dr. Vallis? what,
Yeah,
what do
this
you
is great. Absolutely. See, this is a great scenario, right? So you've got this kind of like, okay, what brings you in? My endo wants me to wants me here. So you're not sure what to do. So what do? You fill the space. You're the expert. You take over and you say, okay, I'm going to get into my assessment room. But what's really interesting about this is that that's not what he said, right? My endo wanted me to come in. So here's what I might consider saying. I would say, James, great. I'll be sure to let the endo know that you showed up. Are we now done? Now,
Yeah.
what is that difference there? What am I getting at here? And you see, what I'm trying to do is I'm actually really listening to him. Why are you here? What brought you in? My endo. Okay, great. So we don't even know if you want to be here. So Alanna, the
Love
questions
it.
that you would have would be appropriate, but only once you've got a connection to James. And if
Yeah.
James is basically saying, I'm here because I was told to come here, and then you start to do your clinician thing, then you're probably going to have the same kind of a connection to James,
Yeah.
which is not a connection, which is kind of being led around. And so when you take a response like this, and I know it must sound challenging to people, but I would say if his answer was my endo wanted me to come, then isn't it kind of consistent to think, well, great, that's awesome. I'll let the endo know you came. And then there's this pause. And
Yeah.
are we done now? Very interesting to think about. And you know what? How will he fill that pause?
Right.
Um,
Yeah,
yeah,
right. And this is what you get then, right? Like if you let there be that space, or that's a shocking thing. I think when you first told me this, I was like, that's brilliant. And I could imagine so many people, you give them that space and all of a sudden they smile or you get this little smirk and they're like, I didn't expect that out of you,
yes,
right? You're respecting my time. And then more
yeah,
often than not, like you were saying, they'll ask something, right? So they see something on the wall, or maybe they read something on social media. Hey, what do you think about? I heard that first person got cured of type 1 diabetes. Did that really happen? And then that can lead into, oh, where are they feeling? They're really feeling lost and they want some hope for the future, right? Or I
yeah,
keep getting diabetes Barbie behind me here on my desk. And it's amazing sometimes when you have those silences, someone will go, oh, is that diabetes Barbie? I got one too. Right. And I had this woman just last week and she goes, I love how the CGM graph is all
yeah,
wonky on Barbie. And I thought, isn't that amazing? Right. Doesn't that lead us into a beautiful conversation about unpredictability of blood sugars, even as someone as perfect as a Barbie? Right. So it
yeah,
can lead us somewhere. And then I
yeah.
think by the time we get to the assessment, it's much more effective because now when you're asking those questions, you're getting them, they're comfortable with you and they're more open and they're giving you more, I think, truthful, honest answers because we've built some trust as well, right?
Yeah, amazing. Actually, it was interesting. We had this conversation recently about your Barbie on the desk. So I kind of checked it up, and Breakthrough T1D was quite involved
Yeah.
in the development of Barbie. They actually worked with Mattel, and the CGM graph is a real graph, actually.
Oh,
One of the T1D or the Breakthrough T1D people who were consulting on the project actually used her CGM readout to
that's
do that. So that's
amazing.
that's really cool. So,
So
but
cool.
this no, notice that this doesn't take a lot of time, right? I'm kind of listening to the rhythm, right? Why are you here? And because what is one of the most important things that we try to draw out of the patient? Motivation.
Yeah.
And so why are you here? My doctor wants me to be here. So it's not me. And so the question that I'm really getting at might be, well, do you want to be here? You could even ask that. And
Yeah.
so most often, as Alanna has said, the person's going to say, well, and they'll begin to open up to you, which is really kind of where you're going to want to go. But sometimes, and equally important, when you get that pause, is the person who says, actually, I think we are done. I really don't want to be
Mhm.
here. And what I would say to us as clinicians is that that's a more respectful way
Yeah.
of ending a session. You could say, well, if you don't want to be here, and the only reason you showed up is because your endocrinologist wanted you to show up, then I'm okay with that. I'll respect that absolutely. But just let me let you know something. If you ever want to come back, I'm here.
Mhm.
And as a psychologist, when I would do this, I'd often say, you don't have to be re-referred. We'll consider this to be kind of a contact. And so I'll chart this as a contact. And if you want to come back to see me, you can just call up the clinic and book an appointment directly. You don't have to kind of get re-referred. And it's fascinating because it's not likely to happen. But even when it happens, I would suggest that when a person doesn't want to hear and the clinician is loading them with information, I don't think the information is likely going to be very helpful, and it may be more respectful. And when I have seen those people who did end the session, they have the most curious look on their face. It's like, oh my God, you've actually listened to me. And it's kind of like, well, thank you. I mean, it's very interesting to see. So what I would say is that when we ask these questions, and this is something that's really important, we are not the experts of the person's life experience.
Mhm.
Our judgment of what a person should be doing is something that is really, we need to be very cautious about, because we shouldn't be putting on expectations. If we were going to put on certain expectations, you should tell every one of your patients that they should run a marathon in 2 hours and 1 minute and 34 seconds, because somebody has run a marathon in 2 hours
Yeah.
1 minute and 34 seconds. So if somebody can do it, you can do it. And notice how easy it is in a transactional world to think, oh, everybody's doing AID. So you got to be doing AID.
Yes.
Everybody's doing this. This is what we expect now. This is where it's going. So why aren't you? And so this is really important. And, this is something that we chatted a lot about. And one of the things that we talked about, I was sharing with Alanna that, as a psychologist in the diabetes care team, I would always be the person who would receive a referral that would sound like this: Michael, can you help this person? They need more motivation.
Yeah.
And I kind of respond, do they need more motivation, or do they need more support to act on the motivation they have? And so when you think about James, it's really something to reflect on, eh?
Yeah. Absolutely, right? And we don't even know what motivates him yet until we really get to know him, right? Yeah.
Yeah,
Give
we don't know
space
what
to
he's
share that.
most concerned about.
Yeah.
Exactly. Yeah. And so this concept of readiness, I love the concept of readiness myself, not only because it's got evidence behind it, but, and I'll say this as clear as I can, what I love about the concept of readiness is giving people permission to not be ready.
Mm-hmm.
That if we take, because you see, the average patient is going to expect that we expect them to be able to follow our recommendations. Right? I mean, if you ask someone to take a therapy, then and they go away and they say, well, my clinician expects me to do it. They wanted me to do it. So of course they expect it. We don't. We don't expect it. We shouldn't expect it. We should expect that they might try. We should expect that they might begin. But we have to be really clear to our patients that it's okay not to be ready, because without support, the patients are likely to give up. And that's where we kind of think about it: understanding the psychology of behavior and using communication skills. Why is understanding psychology of behavior important? Because if you understand what's driving your behavior, notice how we have interventions and outcomes, but what we have to really understand is why a person does a particular behavior. Because if we understand what we call the drivers of behavior, that's where you'll see the intervention really be helpful. And so you could imagine, I mean, maybe James is going to say, well, I thought that's what it was supposed to do. I thought this was like you were there to, and I've seen specialists who say, I don't work for you. I work for the family doctor who referred you. So it's
Mm-hmm.
important that people understand that we need to really ask people what's going on for you. And the best way to get someone to listen to you is first for you to listen to them. And that's where we'll go. And so we thought that James was a useful case for that whole issue of how do you even get started?
Yeah.
And I'll pass it back to you now.
Yeah. So then I'm so grateful we're in a time today where I think on a large scale, we've recognized that teach and tell, we can't just make recommendations and give them to people. And we talk about shared decision making. It's in our guidelines. It's in a lot of the language that we're using. But in reality, I think it's actually difficult to stop and practice this. I'll be super honest with you, right? So we're going to dive into talking about these big decisions, therapy decisions, and I've been no stranger to working with our updated guidelines. I was a part of these, and we were really, really proud to finally have this strong recommendation on the use of automated insulin delivery. And for outcomes, like we have not seen this level of evidence really for any therapy option in type 1 diabetes since I've lived with it in 1994, right? So improving glycemic outcomes, improving those really important person-reported outcomes. But I know that as we're rolling this out, I do continue to hear people go, okay, it should be used for all individuals. There's this really important asterisk here for those willing to wear the device. But also, we have to remind ourselves that this is not written in a language that's intended for people living with diabetes. This is our guideline to guide us on the level of evidence. So as much as this is a should be used, does this mean it's for everyone? And does this mean, how do we now roll this out in practice, right? While still respecting that shared decision making. And I think this is a tricky one because as clinicians, we see these benefits, and selfishly, I as a clinician want everybody on this, right? We're enthusiastic about this technology, but we do have to be careful we don't do more harm than good by pushing people onto something that we think will benefit them if they're not there yet. So I think the best way we can illustrate this is through a case. So here's Stephen. He's a 62-year-old. He's a school custodian. He's lived with type 1 diabetes since his teen years. So he self-manages with injections and a CGM. He tried a pump many, many years ago and didn't like it. So his A1C has kind of consistently been in the eights. He's got lots of variability. So his blood sugars are going up and down. You can even see when you look on his CGM reports, he tends to run high during the day. So we're suspicious, okay, doesn't like getting low at work, kind of wants to put his head down, do his job, and not be bothered by his diabetes. You can tell he's kind of worn out. And so, it's tempting to be, especially I'm very pro technology. I may be, hey, why don't you try an AID system? Right? Have you thought about this? And he very quickly, goes, I am doing just fine with shots. I can do what I need to do. And so this is where we now start to feel a little bit stuck, right? So I've got three different options here, and there's many more. And I can truthfully say I have sat in each of these. So option one, he's doing fine. He's not interested. I should leave him be, right? I'm going to be respectful of him. And I think we have to be a little bit careful here too, because are we more quickly to say they're doing fine based on some of our own biases too? Do we maybe assume he's not techie and so we're going to leave him be? I think we really have to take a check at who we're willing to not explore more with versus who we want to dive deeper with. Now, how about option two? I think this is where I sit the most. The guidelines are telling me everyone should use it. There's really good evidence for this. I know he could do well with this, but I feel stuck. How do I have this conversation? Or how about option three? He needs to get going on AID as soon as possible. I got to talk him into it. Right? How do I talk him into it? And maybe, if you want to be really honest with yourself, pop in the chat which of these you kind of feel with Stephen. Like, what does your gut tell you? And there's not a right or a wrong answer here, but we do feel a little bit stuck. Now, how do I be effective? How do I actually carry out shared decision making from here so that we're meeting in the middle and that he feels informed? What do you think? How can you guide me?
I love this. I love this conversation because as we're describing this, the one thing I'd like us to think a little bit about is what we call distress tolerance.
Yeah.
And I'm talking about our distress tolerance. Notice that, option three is kind of the easiest for us.
Yeah.
Right? Because it's kind of like, this is the data, these are the data, this is what the experience is, do it. And notice that, we're aware that words such as non-compliant, not motivated, those, in denial, those kinds of comments are they used to be dominant. They still exist. We sort of know we shouldn't be doing or thinking those things. But in a way, they're kind of a way of managing our distress by sort of hiding behind the data. And shared decision making requires us not to be in control of the decision. Shared decision making is exactly the equivalent of informed consent. If you're running a study, you have to achieve from ethical standards, informed consent. Well, shared decision making and informed consent are one and the same thing. The decision is the person's. Our job isn't the decision. Our job is the informed piece. Mm-hmm. So if the person has been fully informed, then they're free to make their own decision. And that's something that's important for us because we need to manage our own distress. Mm-hmm. I like to use the traffic light metaphor. And so the history here for this, just to sort of justify it a little bit, because it sounds kind of strange, but I kind of came up with the traffic light. The traffic light has been present in many, many clinical scenarios. It's been used in smoking cessation research. It's used in child healthy eating context. It's a common metaphor. But I worked with Jim Prochaska, the stages of change guy, and we did some studies in diabetes stages of change, and it was great. The work, this model is very valid, except the stages are very difficult to communicate to patients: pre-contemplation, contemplation, preparation, and the evidence doesn't really show that you get 5 different stages. What it does show is some people are ready for action, some people aren't, and some people are kind of on the fence. And so again, we might look at Stephen and think, okay, he's not interested in wearing a pump again. He's red light. So now we need to understand that because we need to understand that when you get this kind of information from different sources, that you often have logical information and then emotional information. And notice that what Stephen presented was, I had a pump 15 years ago. I didn't like it. So he's got experience with a pump. And so for him, a pump is a pump. And so he's got this kind of emotional or kind of horror story. We're so easy to do that. And so when patients kind of respond to our recommendations with some of this kind of hesitancy, it's almost always because of concerns. And
Mhm.
so one of the things that's really important for us to think a bit about is this kind of emotion and logic connection. And I'd like to suggest to us that when a person like Stephen presents with this sort of emotional kind of, pump as a negative experience, how do we actually help him to kind of get to that was then and this is now? Here's the reasons why a pump might be useful to you. I call this the rule of three. It's really quite simple. You sort of say, well, tell me what your concerns are about the pump, Steve. Thank you. That's very helpful. Notice I didn't get into a debate. You listen and you acknowledge that. Thank you. That's helpful, Steve. Is there anything else that you can tell me about your reluctance to consider a pump? Okay, I think I understand what's happening here. Is there anything else you'd like me to know about your reluctance to go on a pump? So notice I'm asking him to express his concerns, but I'm putting it not openly. I'm not saying, how do you feel? End of
Yeah.
story, because humans are storytellers, so they may well
Yeah.
get involved. But I'm saying, tell me why you're reluctant to go on a pump. Tell me more, tell me more. And as you ask again, which is quite straightforward, and we're listening with empathy, this usually takes between maybe 45 and 120 seconds. So this is not a huge, huge task. And it's really important to appreciate it because what we're seeing is how the brain is organized. So this is work that we know from Daniel Kahneman's work. He won a Nobel Prize for this work. The two brain systems, the fast thinking system, which is subcortical in the limbic system, no energy to operate, very emotion based, but very error prone. And then the slow logical system, which is a tremendous glucose hog. It gets fatigued very, very easily. And so this is where the biases come in. And there are a couple of biases that are really challenging for us.
Mm.
So the confirmation bias, which is really this a tendency to look at information and think, okay, what's the focus in on the information that's most consistent with your beliefs? And so you can anticipate that Stephen's going to think about all the horror stories,
Yeah.
right? If you think about people who are looking at, should I get my child a vaccine? And they have vaccine hesitancy, they're going to be paying attention to all the information that they get. And unfortunately, because of what's going on south of our border, we're getting lots of public endorsed information that's completely scientific misleading. But the people that sort of are not likely to take vaccines are going to be seizing upon that information. So what we're trying to support here is that this should be understood and normalized. It's not the end, it's in fact the beginning. And the second bias is what's wrong with what I'm doing now, what we call the status quo bias. And that's why when, Stephen says, well, I'm doing kind of okay,
Yeah.
right? People adapt to their situation. It becomes predictable. It becomes familiar. And so what we're seeing here is that humans have struggles to actually process the risks of doing nothing. So it's almost like the safest thing to do is nothing. So I'll stay right where I am. So just to normalize this, and we want you to think about the shared decision making as an investment in the future, even if it takes more time to
Yeah.
do the shared decision making. The evidence seems fairly clear that you're getting people that are engaged, you're getting people that are actually much more able to change their behavior because what they do is that they meet the clinician where they are, and then you're guided through a journey.
Hmm.
And what we understand about success is that it's not a fast you run. Life is not a sprint. It's the super ultra marathon. It's keeping moving forward. That's so very, very important. I just want to illustrate to you the importance when you're talking about benefits and risks. It's really important that you communicate this in a standardized way. And we've shown that these kind of infographics are incredibly helpful for helping somebody understand the risk. Humans are not good at numbers, and so making it as
Mm.
visual as possible can be really, really helpful. All right, so let's go back to Stephen. I'll
Yeah.
let you pick up here.
Yeah, and I loved how none of this is you're saying that none of this is a race. We're trying to save time in the future. That doesn't mean we need to convince him to number one, does he want to use a system like this? And number two, we don't have to convince him today, right?
Right.
Type 1 diabetes isn't going
Absolutely.
anywhere anytime soon. But also how you're saying this doesn't have to be a 1 hour conversation by making it pointed questions. We're not having to open up all of Pandora's box. So when we're asking and asking and listening, what were his negative experiences? Is he thinking about that old pump 15 years ago that was very non-user friendly, or the harpoon sensors that were those early ones out, lots of alarms? And we joked about this. You came up with, well, it's like that dial-up internet versus what we can rely on technology to do for us today. ChatGPT is at our fingertips. It can really help us. Is it completely reliable? No, we still have to use our brains. We still have to think about the information it gives us, but it sure helps us out, right? So and I think probably what's important here, you could probably share, Michael, is when he's telling us about his past negative experiences, we're listening. We're not saying, oh, but that's not like this one. We actually take the time to hear him out. Also,
Absolutely.
what's most important to him in his diabetes management. You can see there he's scared of work being disrupted. So really hearing out his concerns around managing his diabetes on a day in, day out, and not that his concerns are different than someone else's concerns, different than my concerns as a clinician who lives with type 1, right? And then does he really understand these risks and benefits of AID related to those things that are the most important to him? Right? I say,
Yeah.
I love that I sleep through the night with an AID. That is my experience. That's what's important to me. What he's after is likely going to be very different, right? So we need
Yeah.
to test that out. And does he
When
feel
you
supported? Yeah.
when you describe this, it's so interesting because it makes me think as I'm listening to you how easy it is for us to be problem solvers,
Oh,
right?
totally.
To jump right in. And I find it really interesting because, if Stephen says, well, my work is the concern, then notice that we may have this sort of almost like a reflex to say, well, here's a
Yeah.
solution to that.
Yeah.
What you're describing that I think is really consistent with the evidence to say, okay, Stephen, I think that's great. Thank you. I share that concern. So
Yeah.
if our work together makes your job, your stress at work higher, that's a problem for me too.
Yeah.
So rather than solving the problem, we're partnering with him and
Yeah.
we're respecting the problem, but we're not stopping. We're guiding, and this is so important because it is the critical. And if you're thinking about shared decision making, here's a kind of a self-report instrument, very simple. It's from the Ottawa Research Institute, and it's dead easy. You could put this in front of a patient and say, just before you go, can we go through this? Do you feel sure about the best choice? Do you know the benefits and risks of each option? Are you clear which matter most to you? And do you have enough support and advice to make a choice? And so if you get any hesitancy here, it's awesome because then it's an opportunity to say, okay, we need to spend more time on this. And one final comment before we move on is that, when you said about giving the person time, I think that's so important. Please, you
Yeah.
as clinicians, we are so comfortable with these decisions. We can kind of go into action at an immediate point in time, but we often need to let the patient sit with information for a while, give them a chance to talk to their family members, to sleep on it for a couple of days, especially if it's a therapeutic change that may be experienced as challenging for the patient.
Yeah. Okay. Are we going to rip through this last one?
Yeah, we're going to
So,
rip through
shared
this last
decision
one.
making when we get into these self management pieces. Let's dive into our next case here. That's Juliet. So, 35-year-old, two young toddlers at home, lived with type 1 a long time, using a pump and a CGM, considering AID down the road. That A1C has been creeping up since her last pregnancy. She was in clinic just quickly last time, and you could see those postprandial highs. So, you got into talking about pre-bolusing. I'm a dietitian, right? And what do we hear from her when she comes back in? That's all these shame statements. Don't judge my numbers. My A1C is up. It's my fault. I'm terrible at bolusing. What's wrong with me? All this kind of self-shame, self-blame coming out. And so, this is kind of where my brain goes. There's kind of three things we could look at. Okay, let's look at the big picture. Tell her she's doing really great overall. Maybe we need to dive in and refine some of those strategies because, like Michael said, we're problem solvers. Can we give something to help her, or do we go, hey, what do you want to work on, and make this her choice? Right? I think that's kind of the three buckets we think about, and when we take a step back and we look at what our goals as the clinicians are for her, a lot of these are related to improving glycemia, but also, again, we're helpers. I really want to find a strategy that
Sure.
she can follow through on, and I want to help her at the end of the day. That's those are all the things I'm thinking about usually, right?
Yeah.
And we chuckled over this one. So pre-bolusing, this study on the left here, we've been talking about this. This was published in 2010. We have known for a long time that pre-bolusing is incredibly effective at reducing that postprandial spike, improving A1Cs. Then everyone got wearing CGMs, many people using CGMs, and they see very quickly as soon as they put on a CGM, my food is fast, my insulin is slow. We can see in real time, pre-bolusing makes a difference. And for a lot of people, we do see that positive behavior change, but they're not following through. And why is that? Right? So now I think we have to go back to, well, what are her goals? So since she's had kids, she's thinking, I want to live a long and healthy life, kind of these big goals. I want to be around for my grandkids one day. I want to get off this diabetes roller coaster. But those are really hard to act on. So what I find myself doing in practice more now is getting into the nitty gritty, the daily goals, right? So if we advance that forward and you start really asking her what's bothering her on a day-to-day basis, my CGM's driving me nuts. It beeps in the middle of library time with my toddlers, or when I finally get to a meeting or a workout. I often talk about that high blood sugar. What happens? I have to pee all the time. Oh, you have to pee when you're at the pool with your kids. When it's nap time, you're high again. Or having to eat because they got high and they rage bolus and then they dropped and they're eating because of the low. It's those day-to-day annoyances that usually I think is where we start to get to the meat of things with them as far as what they really want to, or what's going to motivate them to want to change. So I got to hear your perspective on this now. Am I on the
Yeah.
right track?
Yeah.
And how can you,
Yeah. Yeah.
right?
We're talking about that sort of wanting to shift to a relational perspective, really using the relationship. And this slide is really taken from the psychotherapy literature that sort of shows us what is a helping relationship that actually leads to change. And it's sort of a combination, the bond alliance, that professional, respectful caring. We're all good at that. But then we need the goal alliance. And this is why I think you're right on target, is that somehow we need to line it up. And the important thing here, and I've been in the field of diabetes since 1988. And so I can tell you that I feel comfortable making the following caustic statement, which is we are obsessed with hemoglobin A1C and time in range.
Yeah.
We are absolutely obsessed with it. It's the most important goal for us. And we have to get over ourselves because the goal alliance is not our goals.
Mm-hmm.
People generally don't come in with biomedical goals. They want life. They want to have children. They want to raise their family. So you and I have to line up. And so what you were showing us was how you line that up. And when you sufficiently do that, so that the bond is there and the goal is there, and you want to do this work with her such that she's going to have improved time in range, reduce complications, and she's going to benefit by having better relationships with her kids and living longer. Once that's established, the task alliance becomes so much easier. Remember distress tolerance. Your ability to manage the distress is directly related to the value of the goal. And so when you're talking about things that don't show up on a day-to-day basis, only show up in a clinic, it's not going to be a very relevant
Yeah.
goal. And this is where motivational communication comes in. So what it looks like is, as you see here, you kind of start with the reasons not to do something, let's say a person who's not ready, and then we ask, listen, and summarize. Now, this is easy to hear, but not so easy to do. Because most of us, when we're listening, tell me it's not true, you're listening with the intent to respond. So you're
Mm-hmm.
framing up your responses as you're listening. That is not listening from a motivational communication point of view. Listening is listening with the intent to understand. So you park all your expectations, you park all your hopes, just slow down, right? Just take it slower. And the first thing you do is ask, you then listen. Now, how does the patient know that you've heard them, that you've listened? Is you have to summarize it back. So
Yeah.
ask, listen, summarize kind of provides this limbic system discharge. That's the rule of three. And then what you can anticipate when you summarize it back is that the person is going to say, exactly, you understand me. Now, this is called common ground. And remember, the best way to get someone to listen to you is for you to first listen to them. So now that we understand all of the reasons why pre-bolusing is a pain in the butt,
Yeah.
can we talk about pre-bolusing? And what's really interesting about this
Yeah.
is that humans want support as long as they're not being controlled.
Yeah.
Right? So think of learned helplessness and think of psychological reactance. So when we say, okay, so now that we understand all of the reasons why you smoke, and it makes perfect sense why you smoke because you smoke for all of these reasons, can we talk about not smoking? There is no logic check in the brain. And so if a patient doesn't feel judged, if the patient feels that there's a good bond and a good shared goal, and now we're talking about the tasks, they're happy to discuss. So ask, listen, summarize. Now you've got common ground, invite, inform, and you go from the reasons not to the reasons to.
Mm-hmm. Mm-hmm.
And the final point, I'll let you do our final
Oh,
intervention.
no, well, and that's just so like you think about that pre-bolus example, and it's like, okay, so you hate that, CGM going alarm going off at library time with your kid in the morning. So now if I'm starting there, then it's, well, is this right what that's bothering you with? And then we take it from there. But I think it's reminding her now too that the self-compassion piece is so important, and we're not, just because we come up with a shared decision or a shared behavior change or something that's going to work for them, this doesn't mean it's going to happen every single day, right? And diabetes is a beast to manage. It just is. So it's just normalizing, hey, those high blood sugars are still going to happen sometimes. That pre-bolus still isn't going to happen. Or maybe you chose a different strategy, but instead of saying, this is my fault, I shouldn't have eaten at that, or why couldn't I pre-bolus today? That just takes us down this negative downward spiral into distress, burnout, and we do see poorer outcomes with that. So I love to share this with people. This has been well studied, and we've seen this, and we got to get off that. If we can replace that with self-compassion, I always say blame something on the outside. Our insulin is too slow. Those carbs will cause a blood sugar to spike when we have a pancreas that doesn't produce insulin. That is the fault of the food and the fault of the insulin and the tools that we have. And so replacing that with some self-compassion, cutting ourselves some slack, lots of outcomes, and positive outcomes beyond the touchy feelies, which we know are really important. But there's some really strong evidence coming out around this that this makes a difference.
And here's just an example of this from a recent publication. It's actually 10 years old now. In addition to further demonstrating the link between distress and metabolic outcomes, these findings suggest that self-compassion might buffer from the negative metabolic consequences of diabetes distress. So you're all really familiar with diabetes distress. I think we've done a really good job of bringing that concept in. Self-compassion is a key element to managing diabetes. And I love what you said because, if diabetes was sort of a person, it would be obnoxious, right? It would be
Oh,
it
yeah.
would be difficult to please. It would be always demanding. It would be no matter what you gave it, there's still room to go. It's so easy to become perfectionistic. And
Mm-hmm.
so it's so important for us to reflect on, kind of what is the pathway to success? So we see three stepping stones. And so there are three stepping stones to success in terms of helping people to change their behavior and sustain those changes. And the first is adherence. But I want you to think when we use the word adherence, we're not talking about following the rules. We're talking about what you can do. So, Alanna, you live with type 1 diabetes. So I would we would start with what you're capable of doing, what it is that you're doing to manage your diabetes. Remember, you don't compare a person to perfect, you compare a person to zero. You don't
Yeah.
have to do anything if you didn't want to, right? There's no
Yeah.
law that says you must manage your diabetes. And so what are you doing? And then we build on that. And then we use behavior shaping, small successive goals, the power of the small goals. So when Alanna breaks it all down for Juliet, you can see that'll lead to an outcome. The smaller the problem gets defined, the easier it is to find a
Yeah.
strategy. That allows the person to develop confidence in themselves. I can do this,
Yeah.
and allows you the opportunity to tap into intrinsic motivation. So when we talk about behavior change, we're really talking about we support the person for a pathway that they're capable of, that we can help them develop the confidence in overcoming the barriers to, and help them link that to what's important to them. So these are the kind of, and it doesn't matter what the intervention is. So, this is really near and dear to your heart, Alanna, as a dietitian. What's the best diet? What diet should I be on? And the diets, the best is the diet that you can
do.
follow, that
Yep.
you have confidence in, and that makes you closer to the person you really want to be. And it doesn't matter whether that's, keto or
Yeah.
Mediterranean or what have you. The diet is less important than this journey to change.
Totally.
Awesome.
Wonderful. Oh my gosh, we could talk all day. Really, truthfully. I've learned so much just, hearing your guidance through these simple cases and just these approaches. They're so, so important. And I think we all need these reminders of just how to reground ourselves, to slow our paces and stop and listen to people, build that connection. So, so valuable.
This was great. Thank you both so much. There are a lot of important learning lessons in there. We do have so far one question in the chat that I think is really great. Can you speak more about patient goals, but ensuring they aren't telling us the goals they think we want to hear? I often ask patients to share their goals, and they will often say A1C and time and range goals, which I think they likely aren't their own, but probably coming from their medical team. Suggestions on how we can pull out what patient's actual motivation is. Great question.
I love it. Yeah, that's a great one. And remember, I talked about the rule of three from its sort of emotion and how to sort of help the person to sort of express themselves. This is also really true. So here's a good way of understanding. Clinician asks the patient a question. So what happens? Because remember, the dominant dynamic here is that the clinician is in charge.
Mm-hmm.
The patient is coming in because they have a problem and they're looking for a solution. So they're vulnerable. You're a help giver, so they feel you've got more knowledge than them. It's also you have a title behind you, you have a credentials, it's your office, it's your children's picture that's on the desk. So there's all these power symbols that puts this person in a submissive position. And so when we ask a question, the first answer we get is what they think you want to hear.
Yeah.
So you ask it again, and then you kind of get at what they think they should say, and then you ask it again. So the rule of three becomes really important. And what I would say to that specific question is whenever you suspect that, so if you're sitting there thinking, is this one of those situations where the person is telling me what they want me to hear? You can say to them the following: could I ask you a question? That's called asking permission. And you can never ask permission enough times. So you say, can I ask you a question? And pause. Notice that that question creates curiosity. So there's almost nobody's going to say, no, don't ask me the question. But if they said no, then you wouldn't ask them. But the majority of people will say, okay, what? And you can say, are you telling me what you think you should say? Are you telling me what you think I want to hear? And patients are actually good at that because they understand that dynamic. And many of our patients would say, are you truly interested in what I think? Or am I here to sort of, kind of take on the role of the diabetes patient? And so you can have a very open conversation about that. And it's really curious to see kind of what happens. It's that, don't be surprised when you try these methods, you get this kind of pregnant pause. And what I can tell you about pregnant pauses in our clinical work is then A, don't freak out, let it happen, don't interrupt, give the person at least 30 to 60 seconds to respond. And whatever they say will be incredibly important to hear. So don't worry about, because I mean, we hear this often when you do this kind of work. People will say, well, I've lived with diabetes for 15 years and nobody's ever asked me that question. And so it's interesting that we kind of get to that. So that's how I would respond. What about you, Alanna, in this situation where you kind
Yeah.
of feel that people are kind of feeding it to you?
Totally. And I get the same thing with sometimes when you open a clinic visit with someone. I do mostly virtually care. It's how's it going? And they go straight to the diabetes, right?
Yeah.
Oh, yesterday I was kind of high, and they jump straight into because they think they're here for a clinical visit. And so
Yeah.
sometimes I will and correct me on this, you just get into like outside of the numbers, right? Or like with that goal,
Absolutely.
or I just
Absolutely.
had someone the other day and it was, no, what would a day look like for you? What are we really reaching for? Not outside of that time and range, outside of that A1C. What is it in the day that you're wanting help managing?
So
And
does everybody hear what just happened? Bond Alliance, I want to understand how you're doing this more than just a pancreas and goal alliance, and then you get to the task. That's exactly what we described, Alanna, that it's, the person might come in and, yeah, you establish that connection, establish the goal. And as you presented it, it took you like, 20 seconds
Yeah.
to do that.
And then it saves you from, going through all their CGM data, trying to figure out how do we improve time and range. And they're going, just this one I had, she wants to work on the luteal cycle if her period is really frustrating. And I wouldn't have even known that that's where I needed to start, right? That
Yeah,
is what is bothering her right now. So I think it's really getting them to open up to, but you have to have that relationship first, and they have to trust us
exactly.
sometimes to know that we're not going to be there just trying to improve their time and range or trying to get rid of those lows when maybe they're not someone who's afraid of lows, right? Like we make a
Right.
lot of assumptions around what we think might be bothering them. Yeah.
That's
Exactly.
great. I will say, we have time for one more question if someone puts one in the Q&A. I did put a link in the chat for Type 1 support, which
Wonderful.
is the support platform. So it has over 60 courses on practical ways to manage type 1 diabetes. It can be used by healthcare providers and also people living with type 1 diabetes. So please feel free to use and share that resource that I put in the chat there. And if another question doesn't come in the next minute or so, thank you everyone for being here. Thank you both for this really inspiring and helpful presentation on improving the bonds, improving outcomes, and eventually, hopefully, people's lives with better management and more of a team effort in managing type 1 diabetes. Really, really important information.
Oh, thank you. And thanks for recognizing the need for this. I think we
Yeah,
all need,
I
I
appreciate it.
always need this training. It is so easy. All the technology is advancing. It's very, very easy to get caught up in, okay, someone's coming in on this system. What's the algorithm? What settings am I adjusting? What are all the technical things I need to be working on? And we can do so much without understanding all that technical stuff and just taking a step back and bonding with these people sitting in front of us. So this reminder is so important.
We don't have a question, but we do have a lot of hearts and applause, and
Love that.
also a
Coming in.
comment saying, so good to hear these discussions. I need to talk less and listen more. Thank you. Oh, we
Wonderful.
do have a hand raised. I'll see if I can let this person quickly. Oh, it's gone. Okay. Um, Sorry about that. Yeah,
No
no
worries.
hands. Okay. Thank you
Awesome.
everyone for being here. Have a great rest
Thank
of your
you.
Thank
Thank you. Thanks, Alana. That was fun. I
Oh, thank you.
appreciate
I'm
that.
glad
I'd love to
my
do it.
tech
That was.
issues resolved. Oh my goodness.
I know you came in right
Oh,
at the pivotal time.
oh
Yeah.
geez,
Awesome.
right?
Thank
All
you
right.
so
Thank
much.
you,
Have a
everyone.
great day.
Bye-bye.
Bye bye.